Hello and welcome to our first October 2019 Indigenous Pink webinar. I'm your host today, Dr. Gay Lynn Richards. It's my pleasure to welcome you to this webinar and also my privilege to be the American Indian Cancer Foundation Screen Our Circle program nurse specialist. Today we're going to be looking at mammogram screening guidelines. Also, there will be a link to an evaluation in the chat box following the webinar. Please take a moment to fill out the evaluation. We'd like to know if this format works. It's called a lightning webinar, so in 15 minutes, we look at a topic associated with breast cancer and breast health. Also, we'd like to hear from you on other topics you'd like us to present on. So let's get started. Imagine a world without cancer. The mission of the American Indian Cancer Foundation is to eliminate the cancer burdens on American Indian and Alaska Native people through improved access to prevention, early detection, treatment, and survivorship support. Our topics for today, first we're going to step back just a little bit. What is a mammogram and how do we know that they work? Why are there so many different screening guidelines and how did that happen? And then, how do I, as an individual woman, pick the right screening guideline for me? What is a mammogram? Simply put, a mammogram is an X-ray of the breast. There are two views of each breast. One view is from top to bottom, one view is from side to side. The technology has improved significantly over the years in mammography from something called analog in the early years. And analog was very similar to how you might take an X-ray of the arm. So the X-ray is taken, the film is processed in a processor. The technologist takes the film and hangs it on a box that has a light source behind it. And then the radiologist comes and interprets. So that was the analog technology. 10 or more years ago, we moved into the digital age using computers to take the images of the breast. Again, still two views of each breast, one view from top to bottom, one from side to side. But there was a benefit to digital mammography because the test was quicker and also more comfortable because as soon as an excellent image showed up on the computer screen, compression of the breast for positioning stopped. Then the radiologist could go into the computer system and read and interpret the mammogram computer images that way. Also, digital has a software program that's kind of like a second set of eyes. So the radiologist interprets, but then they could use a software program called CAD to take a second look at the imaging. And you can see below, I've got a comparison of digital versus analog, and you can see that the digital images are clearer. Now, in the last 6 to 8 years, there's a new technology called 3D. Tomosynthesis. This has been a really tremendous improvement in the imaging that is available. And part of always our challenge with mammography in days gone by is that our breast is a three-dimensional structure. And both analog and digital reduce a 3D structure of the breast to a 2D X-ray. Well, 3D is similar to a CAT scan. So it takes multiple images through the entire breast structure, then puts it together. So it's really a 3D image of a 3D structure. And then the radiologist interprets. There have been benefits to 3D mammography because the images are so clear that it has reduced the number of women who may be called back for additional mammogram images. It's still really kind of in its early days, and it's not yet available everywhere. Also, insurance plans are still determining whether they will pay the additional charge for tomosynthesis. So if you're interested in 3D mammography, check with your imaging facility to see if it's available, and also check with your insurance plan to see if they are covering it. How do we know that mammography works? Well, when we think about the features of a good test for population screening, and mammography is really population screening, and it's screening mammograms are delivered to women without any symptoms. We really want to look, is it effective? Does it do the job that it was meant to do? Is it safe? Is it widely available? And is the cost reasonable? And mammography meets all that criteria. There's also been very large studies here in America and across the world looking at how well does mammography work to identify changes in the breast before they could be found in any other way. In 1963, the first large study was done by one of the insurance plans in New York, and they asked the questions, could breast changes that could not be felt be identified by mammography, thus identifying a possible cancer much earlier and saving lives? They proved beyond a shadow of a doubt that mammography, particularly in women 50 and older, was able to identify changes in the breast. Thus, treatment could start earlier and lives were saved. This study also propelled other national organizations like the American Cancer Society, the National Cancer Institute, to establish a number of screening studies, and over 300,000 women were enrolled in studies over about 15 years at 29 sites. Studies continue. Scandinavia, Italy, I've read studies from Pakistan, India, China, and I just read a mammogram study from Sweden that was done in 2018, and it continues to show that we can save women's lives if women get regular mammograms. Now, what we know here from studies that have been done in the US, about 30% of women over 50, we could save lives. There is an advantage for women 40 to 49, but it's less. It's between 15 to 17%. Now, I think even saving one woman's life is an important feature of getting regular mammography, because it's the individual woman, but also cancer impacts her family, and her community. So we can do something about this by encouraging and empowering women to ask for regular mammograms. You can see that some of our risk for breast cancer has to do with getting older. Of course, being a female also increases our risk, although men do get breast cancer. About 2,000 men will be diagnosed in the United States this year, but they have a 1 in 1,000 risk as compared to our risk as women of 1 in 8. We still don't completely know the cause of breast cancer. We can understand the risk factors, but we don't really know that underlying cause completely. So early detection is really key to healthy lives and saving lives. A mammogram can detect changes even up to 2 years before it could be felt on a physical exam. And there's almost 100% 5-year survival rate with early detection. Breast cancer is the most diagnosed cancer in American Indian and Alaska Native women, and the second leading cause of cancer death. About 30% of Native women present with late stage, which may impact the kinds of treatments they can have or the type of surgery they may require. Of course, there are barriers to getting regular mammograms, such as transportation, cost, or who takes care of the family while you're at the clinic getting your mammogram. I believe we have the wisdom to come together to come up with solutions to the barriers that a woman may face. You may ask, why are there so many screening guidelines? That seems confusing. Well, I'll tell you, it's not a new discussion. In 1996, a number of the national organizations, American Cancer Society, National Cancer Institute, American Medical Association, and many others came together, and they really determined that an annual mammogram starting at age 40 was the right guideline. Then, a few years later, an organization called Cochrane came out with some reports. Cochrane is an organization that looks at all the studies that have been done on a health topic, and they reanalyze them. And what came out of that is a question about regular mammograms for women 40 to 49. And the next bullet point you see, U.S. Preventive Services Task Force came out in 2009, really looking at should they recommend regular screening mammograms for women 40 to 49. We'd have to screen about 2,000 women in that age group to find one cancer, and we also know in that age group that 10% of those women would be called back for additional imaging or tests. And there's both a cost in a couple of ways. There's a financial cost, of course, but there's also the psychological cost of the anxiety of being called back. The bottom line, however, is no one says don't screen. So we have to figure out what works best for us as the individual woman. Now, this is just guidelines from various national organizations, and we're just going to look at the mammography guideline today. So you can see that most of them say start at 40 annually, or you can choose to start at 40. The second guideline is American Cancer Society, and this is the screening guideline that the American Indian Cancer Foundation endorses. You can choose to start screening annually at age 40. Isn't choice a wonderful word? We can choose to do what is good for our health. Then we absolutely want you to get a mammogram every year between ages 45 to 54. And then again, you can choose annually after that. And you can see the one that's very different is the one at the bottom, the U.S. Preventive Services Task Force. And they don't say don't screen. And the thing that gets lost is that they strongly recommend and encourage all women to talk with their doctor about what is best for them and have that conversation right around age 40 to set up what's right for you as the individual woman. But remember, you can choose. So be sure to talk to your doctor, and it's an informed decision. You look at your risk, what's your preference, and the context. Sometimes someone may have a very serious condition that may be the priority for addressing. So have that discussion. I have given you one risk assessment tool. It's on the computer. It's called the Gale model, and it looks at age, family history. And remember, our family history of risk for breast cancer passes both through the mother's side and the father's side. So we need to understand what's going on both our mother and our father's side. And this model also looks if you've had previous breast biopsies and results or breast surgeries. Again, preference, you can choose to have an annual mammogram starting at age 40. The take-home message I want to leave you with is to get screened. Talk with your doctor. It is a partnership, and make an informed decision that is right for you. We are all individual women, and we should decide what is the best way to go forward around a mammogram screening guideline. Thank you so much for listening today. Please take a look at the evaluation. We'd love to hear from you, and we particularly want to hear other topics you'd like in a webinar format. And if you're interested to join us again, join us on the 24th of October. We're going to look at breast cancer risk factors, signs, and symptoms. Thank you.